Hi everybody, I think it's time to get underway with the webinar. Welcome to the latest Primary Care Direct webinar. Today addressing and trying to understand your ARRS team, the Additional Role Reimbursement Scheme. We have a selection of experts with us today to go through some of the key roles we have been receiving feedback on that are important and that can benefit primary care. Reducing workloads within your PCNs, within your practices, but also for the benefit of patients. First of all, a little bit about Primary Care Direct. We were founded about 3 years ago, and in front of you can see a list of our founding members. We're also a consortium, and the objective is to become a one-stop shop for all of your support needs. To have one phone number for if you've got any questions, queries, or need any support. Some of our associate members are on this page as well, and we have several of our associate members speaking in the webinar today. So the agenda for today, first of all, we'll be speaking with Kieran Johnson from Primary Care Direct, and Kieran will be looking at the roles and how they're being introduced through April 2021. Following which we'll have Matt Taylor from Sano Physiotherapy, Adria at HN, who place health and wellbeing coaches, Nick Matic with PATH, Physician Associates, and Ryan Smith from the Pharmacist Network. We'll be talking about pharmacists. And then it mentions Joanna there, but unfortunately Joanna's been unable to join us today. Therefore, Kieran's going to go through some experiences that she's had project managing and supporting PCNs and practices in implementing these roles. So I'll hand over straight away to Kieran. She's going to take you through some of the needs to know.
Hi, good afternoon, everybody. Thank you for joining our PCN Workforce webinar. I'm just going to briefly touch upon our experiences of the PCN workforce and ARRS roles and look forward to what does April 2021 look like with some of the new roles that are coming on stream. To start with, and from the experience of us working with over 75 PCNs nationally, we've recognised that actually each PCN has different structures of how they recruit their staff and also have recruited and employed different members of staff, and in some circumstances haven't employed anybody at all. So when I was thinking about, what was we going to talk about today, there was like different ways that PCNs have actually recruited their workforce. So some have really looked at their national DES specifications and they're also their population health, and then built their ARRS workforce around these priorities. So maybe that top structure in the pink is probably what that sort of workforce looks like. Similarly, some have used a shopping list approach and have employed a range of staff, maybe based on their population health or based on the DES requirements, but mainly around actually, okay, how many members of staff can they actually recruit based on the budget that they're being given. So more of a shopping list type of approach. There's also some PCNs that we've been working with nationally that have some staff but not maybe recruited to the full workforce that they've been allowed to with the funding that's made available to them. We found that a lot of these PCNs who have got some of the staff have recruited the positions that they're actually quite confident in knowing what they actually do. So this could be a mixture of clinical pharmacists, the social prescribers, maybe care coordinators, whereas some of the newer roles maybe haven't actually been brought on stream. And in some circumstances, we've also worked with some PCNs who haven't recruited any staff at all due to a range of factors. So when we've been working with the PCNs and when we've asked them the question about, why, what's got you to this place of where you are with your ARRS workforce, there's been different approaches to recruitment and different barriers as to why some of these workforce members haven't been recruited. So obviously the key one has been COVID. A lot of the PCNs and the PCN staff have been, responding to the COVID pandemic. But there's also been issues around the employment model. So, originally a lot of PCN started off with a lead practice model. However, as the workforce grows, that it's becoming apparent that actually this lead workforce model maybe isn't sustainable. Similarly, there's been questions around, okay, how long shall we recruit for as well? The end of the DES is March 2024 for this current contract. So do PCNs recruit for the full 3 years now, or do they recruit for the 2 years because there's obviously redundancy implications? So that's also been a barrier as to why some haven't actually recruited to the ARRS workforce. And similarly, and what the reason for this webinar is that a lot of PCNs, a lot of clinical directors and PCN managers maybe don't have an in-depth understanding around what the roles do or what they can't do, but also how do they contribute towards the PCN and the goals and ambitions of what the PCN wants to achieve, and also how do they support member practices, because ultimately the ARRS workforce is there to reduce the burden of general practice. So it's about trying to marry the two together and seeing how they can work together to ensure that actually this burden is reduced. So that's kind of where we are now, and some of the different experiences that we're seeing. Now, I'm going to talk a bit about some of the workforce roles. We all know what some of the usual workforce roles do. So, for example, and I won't talk too much about this because we do have some of the provider services who will come and talk about this. But we do know, for example, that clinical pharmacists can undertake medication reviews, discharge summaries, contribute towards pain clinics, and also support the care homes desk. Similarly, we know that dietitians will support with obesity and malnutrition, and podiatrists can, for example, undertake diabetic foot checks. Some of the others will be discussed, as I mentioned, later on, but I just wanted to focus on some of the two new roles that will be coming on stream from the 1st of April, because there's a bit of kind of a lack of understanding perhaps of what these roles are, as some are still being rolled out as pilots, but it just would be useful to maybe for me to go over some of this, just so that you can maybe identify some areas that these two roles could support your PCN going forward from next month. So to start off with, community paramedics, it's been suggested, and with the PCNs we've worked with, looking at their work plan, is that community paramedics could support with patient home visits, they could manage patients presenting with illness and those with long-term conditions, they could respond to medical emergencies in practice when patients are within practice, and also another area of work that they could support with is examining bloods and x-ray results. There has been a successful pilot within a PCN down south, and I'll just give you a bit of an overview on that. So this is a 13 practice PCN. And they realised there was an increasing workload on home visits. So they did actually an audit of this and found that over half of those home visits could actually be seen by the paramedics. So a paramedic was recruited to the role, and what happens is that a patient requests are triaged by the GP. If it's, for example, an end of life or a complex case, then the patients will be seen by the GP. But otherwise, the paramedics can go out and do a home visit. And then also they are in constant touch with the lead GP throughout the day. As I mentioned, this has been a pilot which has been running for the last, I think, 18 months. And the impact is that more patients have been able to be seen at home. And obviously there has been an earlier intervention as well from MDT, from the multidisciplinary team. Second ones I wanted to mention was the mental health practitioner as well. So you may have read in the NHS England letter that came out, I believe it was last month, that from April 2021, every PCN will be entitled to a fully embedded full-time equivalent mental health practitioner who will be employed and provided by your local mental health trust. 50% of that will be funded by the mental health your local trust, and 50% will be funded through the ARRS Workforce funding as well. And this will increase to 2 full-time equivalents next year, and so on until the end of this current DES. So what does a mental health practitioner do? So some of the examples that we've got and that we've been working with, and some of the pilots is that, an example I can give you is that there is within one of the PCNs we've supported, there is an MDT of a psychologist, some mental health practitioners, and social prescribers. And they're all based within one PCN, and they carry out assessments and provide brief interventions and care navigation for people with mental ill health. So what they do is they'll also support GPs as well with any help, advice and guidance that they need around mental health as well. So the support that they provide is actually twofold. And then it looks at those who need more support than maybe primary care can provide with them around their mental health. But also it could be for those who are transitioning from secondary care back into the community and back into their homes. So some of the areas that this pilot has looked at is anxiety and depression for those who don't meet the criteria for improving access to psychological therapy or secondary services. It could be those who have been recently diagnosed with dementia. It could be those who have serious mental illness but who could benefit from access to other types of intervention as well. Some of the benefits of this approach that mental health practitioners have been involved in is that there's more resources for general practice to access around mental health. There's an improved quality of care. There's a collaborative approach to providing mental health services within the PCN. And obviously, patients don't fall between the gaps as well. And going forward and thinking about, the workforce and the ARRS funding that is made available to you, it might be also worth thinking about how can the roles help with the COVID vaccination programme as that continues to roll on, and also the general COVID response as well. We've seen in some cases that, for example, Physicians Associate have been providing clinical support within the hot hubs. We've also seen in some cases where physios have been potentially been able to vaccinate patients in either the flu clinics or within COVID vaccination clinics as well. There's also thinking about the ARRS workforce and how they can support the current situation that we're in at the moment. I'm going to pass over to Matt now from Sano Physios, who's going to talk about the first contact practitioners.
Okay, thank you, Kieran, and good afternoon, everyone. So my name is Matthew Taylor, and I'm the Managing Director of Sano Physiotherapy Ltd. I'm going to talk to you today about first contact practitioner services. I just want to start by giving you a brief overview of our experience as a business in this field. So Sano have been delivering FCP services since 2018 on the back of a successful 12-month pilot in Leeds, and have since rolled out our FCP services across the UK. We now work with multiple PCNs across the country and are one of the largest employers of FCP outside the NHS. So I'm going to briefly talk to you through the role of an FCP, what value they add in primary care, and from our experience, what makes a great FCP service. So from the first slide, so what's a FCP? A first contact practitioner is a highly skilled and regulated MSK practitioner at the first point of contact in primary care, working at the top of their clinical scope of practice. They work at master's level and must have a minimum of 3 years postgraduate experience in their professional speciality. They provide a first point of contact with undifferentiated, undiagnosed conditions to take the place of a GP consultation. And ultimately, FCPs provide a cost-effective solution to remove the MSK burden from a GP diary in primary care, whilst expediting appropriate treatment and intervention. It's worth noting that a first contact practitioner is not a conventional physiotherapist. It's a very specialist role with associated advanced practitioner skills and training. Next slide, please. So what does an FCP consultation look like? As you can see from the diagram there, an FCP consultation will typically follow this path. A patient will present in primary care with an MSK condition, and they will be booked in to see an FCP instead of a GP by the receptionist. In one session, the first contact practitioner can then assess and diagnose, and that will include screening for serious pathology and red flags. In terms of potential interventions, FCPs will give information on self-care and enable support behaviour change. They can discuss fitness for work, undertake social prescribing, discuss physical activity and health, so for example, smoking cessation and weight management. They can refer to a course of treatment in secondary care, which is commonly either physiotherapy or podiatry, and they can refer to orthopaedic, rheumatology and pain services. An FCP can also request appropriate investigations, optimise medication, and if qualified, can administer joint and soft tissue injections. So a typical FCP appointment will last 20 to 30 minutes in duration and can be delivered either face-to-face or virtually.
I'm sorry to interrupt. I'm just going to dive in quickly. The sound's not great on your presentation. Is there nothing blocking your microphone, is there?
No.
No worries. Oh, no worries. Sorry to interrupt. I just thought I'd mention it. It might be something you might be able to.
Oh, no. Can you hear me better now?
Possibly, yeah. I'll let you carry on. Sorry.
Right. Yeah, apologies about that. So yeah, an FCP will use the same referral pathway as a GP would into secondary care, imaging and social prescribing, and can review the results of diagnostic tests and imaging. FCPs will identify presentations of systemic disease, and assess factors associated with serious pathology and red flags. And they can also refer to a patient to a GP and vice versa. Next slide, please. So this next slide is in relation to FCP appointment outcomes, and this is taken from a paper in the British Journal of General Practice, which was published in 2019, and it provides a snapshot of FCP consultation outcomes for just under 8,500 patients. So as you can see from the chart on the left, 60% of patients attending an FC appointment can self-manage their MS condition with a single FCP contact. And interestingly, only 13% required onward referral for a course of physiotherapy in secondary care. I think the most important point on this slide is when you look to the right of the chart, in that a GP review was required for only 1% of all FCP appointments. Now, these outcomes provide multiple benefits for primary care networks. So firstly, they reduce the number of investigations, prescriptions and referrals to physiotherapy that are usually requested in primary care. It led to fewer orthopaedic referrals being made, and an improvement in conversion rate to surgeries being demonstrated as well, delivering financial savings to the PCN. And patients receive the most appropriate input first time. At Sano, we've used this study as a benchmark for our own FCP outcomes, and I'm delighted to say that our self-management rates for patients from a single consultation are higher than that published in the journal, which is something that we're very proud of. Next slide, please. Okay, so this is my final slide, and I guess the big question for PCNs is what makes a good FCP service? I think the answer to this is to think more holistically than FCP is purely a clinical service. The FCPs are governed by the Health Education England roadmap, which provides clinical quality assurance. What makes the service stand out from the feedback that we've received is the ancillary services that are wrapped around the clinical offering. So our FCP model appeals to PCNs and delivers added value as we offer a full contract mobilisation and IT integration. And by IT integration, I mean data extraction from System 1 or EMIS or Vision to be able to run monthly reporting. Also overseeing smart card authorisation, IT logins, etc., and all the other IT-related headaches in primary care. The training of non-clinical staff to use a front-of-house FCP triaging tool that we call our clinical decision tree, which uses just 3 questions to significantly reduce inappropriate referrals in the service. So a member of the front-of-house team can ask any patient 3 questions to see if a patient is appropriate for the FCP service. And marketing of services as well. It's in everyone's interest that these services, the utilisation is as high as it can be. In the rectangle on the slide, you'll see the clinical service elements, which are obviously crucial. Recruiting good quality practitioners aligned to the HE competencies is crucial. Conducting our mandatory training and providing guidance through the roadmap. And support for PCNs with clinical supervision, which is key and can be either a taught or portfolio route, and we can facilitate both. And the use of patient convenience tools for exercise prescription. For every patient attending one of our consultations is pushed exercises and appropriate resources direct to their smartphone or email via a unique app. And the last 3 points, for every PCN that we work with, we provide them with a named key account manager who is a single point of contact responsible for overall contract performance. And they audit services on a monthly basis and feedback at PCN meetings to make sure that PCNs have visibility of key service metrics so you can measure what matters. So from our experience, it's clear that clinical services are only a portion of an effective FCP service. And my advice is to make sure you spend time looking at the ancillary and value-added services that you're wanting from FCP. So you can align it to your FCP. Your FCP services can be aligned to your PCN's vision and values. Okay, so that's all from me. Apologies if there've been some issues with the sound there, but thank you for listening. I'm happy to answer any questions, and my details are on the slide if anyone wants to make contact with me directly. And for now, I'll hand you over to Adria at HN. Thank you.
Thank you. And Damien, can I just check if my sound seems okay? Just
Yes, pretty good, loud and clear. And thank you to Matt, and apologies for diving in. But yeah, thanks, Adria. Go ahead.
Thanks, Matt. Hi, everyone. My name is Adria. I'm head of partnerships at HN. We provide health and well-being coaches to primary care networks. And so just a very brief background on HN and what we do. So HN is a healthcare company that delivers AI-guided case finding, clinical coaching, remote patient monitoring, and virtual ward solutions. And all of our solutions are focusing on supporting patients to enhance their motivation, to help them better self-manage their care, and when appropriate, seek the appropriate resources within the healthcare system. Of course, the goal with this is to enhance the efficient allocation of secondary and primary care resources so that patients only seek care when it is needed. We've worked across the NHS. We originally came from Sweden 6 years ago, worked across the NHS starting in secondary care. And as of 12 months ago, we began our work working with patients identified in primary care as well. And recently, we were accredited, our training for health coaches was accredited by the Personalized Care Institute, and we're looking forward to integrating more and more within delivery of care across the primary care sector. If you could go to the next slide, please. So HN's traditional service, clinical coaching, this is just to provide an overview of what clinical coaching does, and then I'll speak about it in the context of primary care. So our clinical coaches work with patients to develop a care plan focused around the patient. So what a clinical health and well-being coach would do is a mix of motivational coaching and health literacy, health education, so that patients can understand, the implications of whatever diseases they're dealing with and how to navigate that disease, as well as providing some level of care coordination and social prescribing. Now, of course, as Kieran already discussed, care coordination and social prescribing are roles that are popping up within PCNs. So now the key is when our clinical health and well-being coaches integrate within a PCN, they work to ensure that they're integrating within the multidisciplinary team, because it's key that you don't want to kind of replicate efforts that are already happening across the PCN. So the first thing that happens for any of our clinical coaches when working within primary care is to make sure they're integrated with other teams. Now, our clinical coaches deliver care remotely over the telephone. Initially, the first meeting was face-to-face, but of course, because of COVID, this has fully switched to remote. And interaction with the patient begins rather frequently, several times in the first week. And then as the patient gains more confidence and awareness in developing their care plan, the frequency of the phone calls dwindles away. Now, we, because the service is delivered remotely, we recruit nationally, and so no matter where you're PCN, there's no problem to deliver a health and well-being coach. If you could go to the next slide, please. So this is just to highlight, as our clinical coaching initially started in secondary care, we ran a randomized control trial across several sites in the UK. Results from the RCT will be published later on in 2021, but we demonstrated results in reducing electivity, not only non-elective and elective admissions, but also A&E visits. But more importantly, we also demonstrated improvement in patient-reported outcomes, both through patient activation, as shown by an increase in PAM13 levels, and also the SF12 survey. Next slide, please. So, and there's a variety of patient stories. I think it's most important to hear what a patient's perspective in working with a health and well-being coach to understand what they do. So feel free to visit our website to hear more from the patients. So now if we look in the context of PCNs and what it means to recruit the health and well-being coach and where HN may be of assistance. So as Kieran alluded to in the beginning, there have been some challenges potentially with some of these newer roles that haven't been recruited, maybe because people aren't aware of them. Also, there could be employment liability challenges, looking at the life cycle of how long you're going to keep people employed. And so one key challenge that HN aims to address is we employ health coaches. We recruit them and we train them using our PCI accredited training. So the employer responsibility lies with HN. The PCN does not have to worry about that. Then once the clinical coach is provided to a PCN, we work early on to make sure that they're integrated with your team. And also it's key to understand what patient is most suitable to work with a health and well-being coach. Often it's patients with comorbidities, but it's important because there's often several programs involved at a PCN that there's a clinical discovery meeting where the clinical team can work with the clinical coaches to understand, all right, how are we going to point a patient in your direction? And if you need to then refer the patient onwards, what is the process within our PCN? Because obviously it works differently across different sites. And obviously the overall goal is not all patients need to be seen by a GP, as Matt discussed. And the goal is that the health and well-being coaches can reduce some of that burden on GPs. If you could then go to the next slide. So this is just to give an example, because as some sites are working to recruit and understand how many of each they should do and what are the cost implications, this is just an example to understand how our health and well-being coaches work. So if you're a medium-sized PCN with a patient population of around 50,000, let's say that you wanted to hire 4 health coaches. So those 4 health coaches would work each with 100 patients, so 400 patients a year from your PCN would receive personalized care from the health and well-being coaches. And this would be at the cost to the PCN would be within the envelope you receive for 4 full-time health and well-being coaches from the CCG. So there's no additional cost, no training costs, no recruitment costs for PCNs who want to hire health and well-being coaches for us, because we're very conscious it's important that it fits within ours. So there's no additional cost for a PCN. And of course, we have the target patient volumes, and there's quarterly meetings and feedback to make sure that the whole process and integration within the team runs smoothly. So I'm happy to provide more answers, answer any questions that there may be, or please reach out with any questions. I think if you go to the next slide, you'll find my information there. Feel free to visit our website as well for more information. And next, I will be passing over, I believe, to Nick, but I could have that wrong, sorry.
Perfect, Adria. Thanks very much. All right. Nick Mattick from Physicians Associates.
Hi, my name is Nick Mattick. I'm from Path Physician Associates. We are a specialist company specialising in the role of physician associates across the UK, and we also work on recruitment of US PAs coming into the UK to help support and build the leadership and academic infrastructure for the new roles coming into the UK. So first slide, please. So I'm just going to very briefly talk to you about what could a PA do in general practice. So PAs are trained and qualified generalists, clinical practitioners that can participate in every aspect of general practice. So as to give you a bit of a guide, they really sort of fit in at GP registrar level within a practice. They deal with undifferentiated and undiagnosed conditions across the full range of everything that you will be seeing in general practice and in the PCN. In effect, the PA is going to be bottom slicing the work of the GP, freeing up the GP to see more complex cases and have more time on their hands to be able to see those more complex patients and to manage other patients in the back. My apology for the dog in the background. So they are very much part of the clinical team and employed within the practice. We would hope that if you're employing newly qualified PAs, as you move forward with building their experience and competencies, they would start to move into some of the more specialist clinics around sexual health, family planning, minor surgery, dermatology, for example. We want to make sure that your PA are reviewing, analysing, actioning in those diagnostic tests, and that they are there to help you support and meet those clinical targets as part of QOF. And they can work across the whole of the PCN, or they can be based in one practice but do the workload for the whole PCN based in one practice. Next slide, please. There are some key things that PAs aren't yet able to do in GP. Now, things are changing on that aspect. So currently, PAs are not able to prescribe. There are workarounds that you would need to put in place to enable the PAs to be able to obtain prescriptions for patients. But as it currently stands, PAs can't prescribe or request ionising radiation. Now, I'll come on to a bit later what is changing in the future for PAs around that, that's currently the situation. Also, PAs are not able to work without access to a supervising GP. Now, that sounds that it makes things very complex, but in reality, it would be no more than the supervision that you would offer to any other member of your clinical team, whether that be a nurse, a pharmacist, physio, or someone else. So although there is a lot of talk about PAs and supervision, it is no more realistically with an experienced PA than you would have for any of your other members of staff. Obviously, you would need to have in place your normal formalised supervision sessions as well, as you would with anybody else. So there is a difference, sorry, next slide, please. There is a difference between newly qualified PAs and the experienced PAs. So there are some key things that you do need to have in place as a PCN if you are recruiting newly qualified PAs. So they are going to need some sort of a program of training across the course of a year to get them up to speed. Now, they are trained and qualified professionals that are coming into your practice, but they do need to learn the art of general practice. They are going to need help with building their confidence and their competencies, just like anybody else that would be new to general practice. But it's best to have and put some sort of support structure around their learning across the course of a year. And certainly PATH would be able to help you with establishing a preceptorship program, as it's called, or an internship, or an introduction to GP. And it's important that across that year, that structure enables them to learn every single aspect of general practice and become confident in those competencies around that. So your newly qualified PA will be starting on sort of in their first week, their first month, in 30-minute appointments under supervision for each appointment. As time moves across, certainly to 3-month point, we'd be looking at PA starting to do 20-minute appointments and requiring a sort of check-in with the GP after perhaps each clinical session or at the end of each day. The ultimate goal, obviously, is to get to the 15-minute appointments and just doing a normal weekly and monthly supervision. And that would probably usually take somewhere around 12 months. So we talk about a preceptorship year, but it's really more about waiting until we get to the point of confidence in the competencies of those PAs. It's clear from a lot of what we've seen around with various practices and PCNs that newly qualified PAs are not suited to multi-site working. There's quite a few PCNs that are trying to get their PA to perhaps newly qualified PA to work across all six practices from day one. Unfortunately, that will lead to role failure. So it's important that while you're precepting your PA, that you are perhaps only keeping them to working in one site, possibly increasing to 2 or 3 sites after about 3 to 6 months. But again, it all comes down to making sure that the supervising GP of any newly qualified PA is confident in the competence and confidence of that PA before they start enabling them to work across multiple sites. It just helps their learning to settle everything down. And of course, another important thing is to see if it's possible to enable peer networking of your newly qualified PA across the area. There may be other PCNs that have newly qualified PAs. You may have multiple PAs joining, multiple newly qualified PAs joining your practice group, your PCNs. So make sure that there's some way of enabling them to perhaps have group learning and teaching together as a group, because that will certainly help move them through the processes a lot quicker. And of course, planning is essential. So make sure you've planned your recruitment, planned your preceptorship and your training across the course of a year. Next slide, please. So there are some key points to the role of physician associate. So a physician associate, they would have had 2 years of training before they come out to you. That would be in clinical rotations and academic learning across those 2 years. Then in addition, they will have their preceptorship program with you. The PAs, once they've qualified from university, will have to register with the PAMVR, the Physician Associate Managed Voluntary Register, which currently sits with the Royal College of Physicians. They'll have to maintain about 50 CPD points across the course of each year to be able to maintain their registration. And every 6 years, they will have to recertify as a physician associate to carry on working. Now, as I mentioned, the PAMVR is shortly being replaced by the GMC, who are taking over the regulation of PAs. And that's likely to happen now, more realistically, early 2022. And then the hope is that prescribing will shortly follow for those PAs later into 2022, maybe early 2023. But it all depends about how the regulatory body, the GMC, how that manages to sort of bed itself in properly. Currently, you can only recruit PAs from the UK and US. There are other countries that have a physician associate programs across the world, but they're currently only recognised from the UK and the US. So if you are recruiting, make sure that they are UK or US based. And I think it's important to highlight as well that there is some sort of myths around PAs stealing the work of doctors and nurses and stealing training time. That is not the case. We're all, PAs are there to help support a multidisciplinary team to ensure that there are enough patients to go around for everyone. So nobody's there to steal those jobs at all from anyone. They're there to support a multidisciplinary team in a PCN or in those practices. Now, your ARRS funding for PAs is around Agenda for Change Band 7, which is up to about 53,500 in total with add-ons, which gives you quite a wide window of which to work with your PAs. And that doesn't include London waiting. So unfortunately, you can't get London waiting for your PAs. So you will maybe have to make some arrangements around some additional income from elsewhere. It is very difficult to recruit those PAs at the moment, particularly the newly qualified. There is quite a bit of a bun fight in some areas for those PAs, but there are more coming through the system. Every 3 months, a new cohort of PAs are released out into the big wide world. So it's worth planning your recruitment as to try and time it to meet when those cohorts come out. And certainly you can contact PATH and we will be able to help you and advise you and support you in your recruitment. And I think it's important to also just say that it's if you are investing your time and money in training up a newly qualified PA, that you do get in what you put out. So it's worth, if you are expecting a newly qualified PA to walk in the door and get on with things, you're probably not going to get the best results. By investing some time and money and effort into that newly qualified PA, you will hopefully get fantastic results from those new qualifieds. Moving on, please. So there are some key points about before you make your decision about recruiting PAs. Are you going to be able to realistically support a newly qualified PA, or would it be better to start to look at recruiting experienced PAs? If you are looking to recruit experienced PAs, there are very few and far between. So you may need to do some additional planning or certainly up your recruitment spend to be able to attract those experienced PAs. Newly qualified, there are quite a few more of them available, but they do require that clear investment in time. Of course, if you are recruiting PAs into your PCN, it is important that you have a clear prescribing process for them as they are unable to prescribe. How are you doing that prescribing with your other roles that aren't able to prescribe with your nurses? Is it the door knock? Is it the use of the duty doctor? Perhaps you can use EPS and the duty doctor to do that. Whatever process you put in place to deal with prescribing for PAs and for your other staff, it's important that that's a written process. It's very clear for everyone to understand from day one. With the role of a PA, it's important that everyone from the GP receptionist through to everybody else in the practice, the GPs, the pharmacists, everyone understands the role of the PA and what role they are playing within the practice and the PCN, so as you can get best use and make sure that you're using the PAs to the full scope of practice. If you are using them to the full scope of your practice, you are setting them objectives to get on with work. Hopefully you will get some really good results out of your PAs that you can use across the care homes, across home visiting, early cancer diagnosis, all those sort of things where PAs can really start to get involved. But encouraging and enabling the networking of PAs locally will allow you to be able to see where other opportunities present themselves for PAs to be able to use in general practice as well. Moving on to sort of last slide. If you are investing a lot of time, money and effort into your physician associates, it is important to make sure that you're looking at retention beyond that first year. So what are the options afterwards? Well, there's clinical leadership, allowing your PAs to take a leadership role within the practice, perhaps looking into subspecialty development within the practice, dermatology, cardio, urgent care, secure healthcare is another new one that's coming through shortly. So these are really important things to start to think about beyond year one. There are, of course, PAs have been added to the partnership network funding now as well. So there are a number of PAs that are partners in practices. So this would encourage retention of your PA moving forward as well. So it's important that you start to think about retaining your PAs after that investment of time as well. So final slide, please. The key takeaways, I think, from that little talk about PAs, do you have the time to support newly qualified, or are you going to be looking for an experienced PA? Are you able to ensure that your PA works at the full scope of their practice to get the best from them? And PAs really aren't that mysterious. The other roles are quite well understood, the role of paramedic or a physio. PAs seem to be sort of these mysterious beings. They aren't. They are there to practice medicine and hopefully just help support the GPs to give them more time to be able to get on with the more complex work that they can do within their practice and PCNs. It really is a great addition to any team in a PCN. Thank you very much.
Thanks, Nick. That's great. And we'll hand over to Ryan after we've just double checked your contact details are there. Yes, they are. Just a reminder to everybody, the slides will be shared with everybody who's registered and attended after the webinar. So you have a hand over to Ryan at the Pharmacist Network, and we'll take you through the role of pharmacists and how they earn pharmacy technicians.
Wonderful. Thank you, Damien. Just before we kick off, is it okay to check sound okay? Hear me all right?
It's a little bit echoey, if I'm honest, actually, Ryan.
Okay. Not ideal. Let me just.
That's better.
Is that any good?
That's much better.
Wonderful. We'll go with that. So, thank you very much for today. It's a pleasure to join you to speak about pharmacists, pharmacy techs. What I thought we'd do is keep it quite conversational and focus more about the questions that we get asked in our roles in working with general practice in partnership with PCNs. So in the spirit of that then, first of all, I'll give you a little run through as to myself and who we are as an organization. And then we'll kick off with some of the key questions really. So Pharmacist Network, we partner with individual practices, PCNs, federations, general practice at multiple levels really, to support with the recruitment, the training, and the ongoing management of GP pharmacy teams. So that encompasses both pharmacists and pharmacy technicians. We offer on-site and remote solutions. So ideally what we'll do is we'll sit down with a partner and we will discuss your needs and work out a system that is going to fulfill those needs. And as I say, it's tailored to you, whether it's a blend of remote, on-site, whatever it might be. That's generally the approach. So straight into it then, key questions. First of all, probably the introduction to this is that I'm sure we're not going to cover all of this in the adequate level of detail today. So what we'll be doing is we'll take a bit of a whistle stop of the top line questions that we get asked when we're working in partnership with practices. And of course, you've got my details, and I'd welcome anyone that wants to have a discussion about your own PCN or practice to get in touch, and we can follow that up. So hiring a pharmacist in your PCN. Many of you probably have a history of bringing pharmacists into your practice, whether it's your individual practice or your PCN or actually through a CCG. I think the key really is, and one of the key questions that we get asked, is understanding the difference between pharmacist roles and what those differences mean in terms of background, how they translate into the activity that can be expected of the pharmacist, and really ensuring that you've got the right blend of patient-facing activity, of audit, and all the many other things that a pharmacist might do. So jumping into one of the questions then, is my pharmacist an independent prescriber? Do they need to be an IP? Well, the short answer is if they're not an IP now, under the PCN vision of the 18-month pathway in the program, there'll be an IP very soon. If you as a practice and they choose to complete that IP qualification under that period of time. So perhaps a lot of stress from some practices around not having an IP, when in reality, a non-IP often, depending upon experience, may not be far behind an IP in terms of clinical knowledge, experience, and competency, and their comfort with dealing with certain situations, such as structured medication reviews. So that leads into another key question. What should I pay a pharmacist? Well, pay depends on a lot of things, as I'm sure you're aware, both experience, qualification, the element of risk in their role, what it is that they're doing and how they do it. So one example being, I've seen, and we've worked with practices who've hired IP pharmacists and brought them in on a really a fairly hefty salary. When they've got into the detail, they've then worked out that actually I've got an IP pharmacist here, but this IP hasn't really done an awful lot in general practice. They're not very comfortable dealing with long-term condition management. They've essentially got the IP, but they haven't utilized it in a big way. So what you should pay them often is quite a deeper question around what it is exactly that they're going to be doing when they come in, and are they safe in doing that? Are they going to be safe, effective, and competent? So further to that then, how does a pharmacy tech differ to a pharmacist? Well, again, there might be a real broad level of knowledge here on the call, and there's no shame in not knowing the answer to this one. I've had questions from PMs in the past where they've asked me, what is the difference? Can a pharmacy tech do the things a pharmacist can do? Well, broadly speaking, the answer is no. Pharmacy techs out there right now, for the main, we are hiring pharmacy techs who've got a background in community pharmacy, because quite simply, pharmacy techs with GP experience don't really exist as a population of people that we can recruit from. There is naturally a migration of pharmacy techs from community pharmacy into GPs, but they do need the right level of structure, support, guidance, training, and they do also need the right level of oversight from a competency perspective. But they can also be a very valuable addition to a pharmacy team. So they can run audits, they can work out which patients are to target in certain areas and which need a follow-up. They can triage, they can handle discharge letters. They can interface with your prescription team if you've got a prescription clerk on site or a medicines manager, whatever that might look like really. But the key is understanding those different roles and how they blend together as part of a system. So further question. What about the other pharmacists that come into my practice? You could have many overlaying services from CCG, PCN, Federation, wherever it might be, and these pharmacists could be doing very different things on all levels really, whether we work with outreach services from a trust, whether it be from a CCG. It's really important to ensure that the work plan is set up in such a way that your pharmacists are doing the things that they should be doing and less of the things that they shouldn't. And that might seem like a really simple thing to get right, but some of the nuances with the way that a CCG pharmacist might work, for example, if you don't slot your PCN pharmacist in the right way, they could be treading on toes, they could be duplicating work, wasting each other's time in some ways. So it is really important to be clear about the way these people are working. Performance. One of the key things really is, how do I track performance? And that's a key question on a national level. How do you as a practice set the right level of expectation for a pharmacist? How long should they have as an appointment slot for a structured med review? And how should I track that performance? Some of the things that we've seen in general practice, and I've seen personally, with the best of intentions, have turned into things that have been quite disastrous from a retention point of view, where pharmacists have been perhaps performance managed on volume of work without a full appreciation for the complexity of certain elements of work. So in reality, you might be getting more value out of your pharmacist if they're engaging with secondary care, speaking to consultants about why certain treatments have been stopped or started, than you would if that patient is a very simple patient that takes 2 minutes to sort. So I think on all levels, really, having that very in-depth understanding of why a pharmacist is working in a certain way and what you should expect and can expect. That's kind of one of the key reasons that we're brought in to manage that situation. Supervision, clinical supervision then. So under the PCN contract, under the GP contract, it sets out a need for the pharmacists to have supervision. We try to take care of as much of that as we can, with the exception of our senior pharmacist needs a level of GP oversight. And through that, we set up the right structure and the right hierarchy so that that clinical oversight is provided to all elements of that GP team. So if we've got pharmacy techs, we have them reporting into and supervised by our pharmacists. If we've got junior pharmacists, they're supported by a senior. And the GP really sits as a partner at the top of it as an additional stakeholder to that supervision group. But it becomes less onerous for the GP, and that's quite key, I think, given how busy a GP's life is right now, no more so than ever. So progression in the role, long and short of it is you may be bringing pharmacists in at the very bottom end of a band 7 with very little experience as a non-IP, and you will be hoping to get them to an IP level, maybe a band 8A, 8B over time, where they're dealing with very complex things and they're adding to the long-term condition management piece in a much bigger way. I think the key for us is that you've got the right blend of staff, you've got the right skill mix, you have the right levels of retention with that. You don't have a team that's too one-dimensional, where there's no sort of scope for growth, but also financially, it makes good sense to have a band 7 doing the job of a band 7 and not a band 8B doing the job of a band 7, clearly. When in some ways, the nuances between the way of working can be quite tricky. So we offer advice on all of that. So in the interest of time then, what I'll do is I'll jump onto the next slide and we will just have a quick scan over some of the benefits really. The way that we work, broadly speaking, we will hire and we do hire within the additional roles reimbursement budget. And we offer support around that to ensure that you achieve all of these savings and efficiencies that you might not otherwise see. So from day one, when it comes to offer letter and offering a role to a pharmacist, we'll be there to hold your hand really and support you through that journey. Offering advice right through training, development of the team, and providing the resources to get them to the right level, both operationally and clinically. So yeah, in a nutshell, I think the key thing is really, as I say, a very whistle-stop tour of some of the questions, some of the key points. But if you want a real meaningful, in-depth conversation about how we could partner with you, whether it's one PCN pharmacy technician or it's a team of 10 pharmacists that you're looking for, we're working nationally as the Pharmacist Network, and our details are there for you to contact us should you wish to do so. Thank you.
Thanks very much, Ryan. That's great. And yes, shame we couldn't see you on video, but yeah, the sound was great after that. So thank you very much. Hand you over to Kieran now, just for a few key takeaways, and then we've got a few minutes left for questions at the end.
Thank you very much, and thank you, Ryan, and everybody else for your in-depth discussions around the various different roles that are available to the ARRS workforce. So we did have Joanna here from Chalfont PCN, who was due to come and talk about the good, the bad and the ugly about recruitment and embedding staff within the PCNs, but unfortunately COVID vaccines have taken priority. So what I thought I would do just for the next couple of minutes is just think about some of the takeaways of this webinar for yourselves. As I've mentioned before, we've supported over 75 PCNs nationally, and I have been project managing with 3 of those at least around the recruitment of ARRS workforce. So some of the things that I'm going to discuss now are some of the things that have given me a headache as a PCN manager within several different types of PCNs, but so hopefully there will also be kind of shared experiences that you have as well within your PCNs. To start off with, something that has given us a bit of a headache and something that we've had to discuss with the clinical directors is around line management and supervision, which I know is being covered by Nick and Adrian, Matt and Ryan. But it's like kind of who is managing those roles. So we've had some cases where there have been providers providing, for example, the social prescribing link workers or the health coaches, and that has caused some kind of concerns around the level of control, in the sense of actually, how much control do we as a PCN have in what they do in their day-to-day operational work. And also, there is often some inconsistency about standards as well that we've seen, and we've had to have meetings about and have a discussion about, but they're easily solved by having those open channels of communication. It's also the same with a lead practice model as well. Is if it's being line managed by a particular practice manager, they may have a different style of line managing in comparison to another practice manager within another practice within the PCM. So how do you overcome that? And again, that's through communication that we've been working with, but obviously there are other things to that as well. And similarly, clinical supervision, some of the questions that we think about when we're working within PCNs is who will be providing this within your PCN. If you've gone down the provider route, then as the other speakers have mentioned, they could be doing the clinical supervision. However, there is a requirement within PCNs that actually there is some GP supervision. So which GPs are doing that? Is it one GP? Is it several GPs? Within our PCN managers huddles, we've also had the discussion about actually can clinical supervision be outsourced as well, and that's something that actually sounds quite interesting. And I know that one PCN has kind of used this approach. So what does that look like for your PCN? I know that the PCNs that we've worked with, it looks very different in each of those. Similarly is also, what about all the required courses and the trainings that GPs or whoever is doing the clinical supervision needs to do? Are you aware of all of those things that need to be done, so that actually the appropriate clinical supervision is provided and those boxes are ticked? And something a bit more operational is around location work and equipment. We often get asked, and I often ask myself, is actually where will these members of staff work? Premises is at a premium. There's not enough space in some practices to accommodate more staff. So actually, where are these members of staff going to work? Where are they actually going to have a desk? What about their equipment? How are laptops and phones and any other equipment that they require? How is this all going to be funded? And the same with the work plans. We've recruited a lot of staff within a PCN, but actually now it's trying to understand what is it that they have to do. Where there's some confusion around some of these roles, it's very hard to develop a work plan. So it's kind of finding a balance between everything that a PCN requires, everything that a practice requires, and having that level of understanding about actually what these roles can and can't do, and making sure that actually it's all realistic and relevant to the post. I have seen it in some cases where a member of staff has started within a PCN, but there has not been any work plans in place for them, to the point where they've actually left because there isn't anything that they have got to do, because that's not been prepared in advance. And similarly, we've had members of the team who have joined and then thought, oh no, this isn't the job for me, this is not what actually it said on the job description, and they've left as well. So a key takeaway I would suggest is have a think about what is it that you actually want your ARRS workforce to do, and actually make sure that is articulated to the member of the team, but also to the practices and to the PCN board as well, so everybody is very clear about actually what it is that member of the team is doing. Another takeaway I would suggest is relationships and how to embed your team members within the practices. That we've done various different sessions with practices across the PCN about these are the roles, again, these are what they do, what they don't do, this is how you can refer to them, these were how they'll be supervised, this is where they will sit, this is where they'll be on a particular given day. And we've done quite informational sessions for the practices within various PCNs, so to make sure that they understand actually who this new member of the team is and what they are there to do. So, have a think about, well, actually, is that something you could do for all the practices within your PCN as well? And similarly, what does your PCN team look like as well? In some cases, PCNs may have like 26 members of staff. So that is a team in itself as well. So what does that look like? What is the culture within that PCN team? What is the level of consistency? What are the standards of the PCN team? So have a think about some of the softer things that actually, when we're building a team, that we may often forget. And thinking ahead as well, as the ARRS funding increases, and there's going to be, an increase from the 1st of April, what do your priorities look like now in comparison to what they looked like maybe 18 months ago when the DES started? What are your priorities now as a PCN? What is your priorities now within your patient population? And does the ARRS workforce that you built a workforce strategy around, does that reflect your priorities now? And it's always very good to keep looking at actually what your workforce recruitment intentions were, what they are now, and what they look like in the future as well, because things change. And I don't think there's a greater example of things changing as where we are now with the pandemic. And finally, have a think about your employment models as well. As I keep saying to the PCNs that we work with, potentially you're going to maybe have £1 million, £2 million worth of staff within your PCN. Is your lead practice model really relevant and fit for purpose? Is there another way that actually these members of staff can be employed? And so it's having to think about, well, what does this look like in another 12 months' time? And actually, is it sustainable the way that you're employing these staff, you're line managing these staff, and you're supporting these staff in the current ways that you're doing it now? So they're just some of the key takeaways that I have from working with so many different PCNs and from my role as project managing as well. Thank you very much for listening.
Thank you very much, Kieran. Thanks to all of our panelists. Really informative, lots of information squeezed into a short period of time there. So thank you to our attendees for joining. Now, we've buffered right up to 2 o'clock there. I mean, we can hang around, and we'll hang around for 3 or 4 minutes if anybody has any questions and they want to ask them submit them through the Q&A facility. We did receive a question for Matt earlier on. Thanks, Matt, for responding to that in the Q&A section. But people who are still logged on can look in the Q&A and see in the answered section. And Matt addresses a care navigation pathway that he uses. We do have one question. No, that's just some compliments. Thank you, Janice. But yeah, we'll be hanging around for 2 or 3 minutes. And if anybody has any questions, do feel free. And we will be sharing the slides. We'll be sharing the recording as well. Thank you again. Hi, Mike. Sorry, I saw you. Saw your hand up earlier, but yeah, do fire away with your question. If you're able to unmute, Mike. Hello.
Sorry, can you hear me okay?
You can, yes. Hello, Mike. Yeah.
Okay, good afternoon. Thanks for that. Very interesting. Just a quick query in relation to the PA role, and indeed any of those patient-facing roles that we're discussing, which we do have in our PCN. Indemnity is something that's an issue in terms of the duty of care lying with the patient who, with the doctor who the patient's registered with. Who funds the indemnity of those various roles, whether it be the PA or the pharmacist, or indeed the earlier one, which was the social prescribers and those kind of roles?
Nick, I noticed you've unmuted, so do fire away.
I did indeed, yes. Yeah, hi, Michael. So physician associates, they would fit in under your normal government-backed NHS primary care indemnity program that all of your other staff that you would be participating through. In addition, most PAs in general practice, they would have their own top-up professional indemnity insurance. But your professional indemnity would cover you, and the practice indemnity would cover you under all circumstances for that, as you would under any delegated authority role.
Yeah, it's just with them working across a number of practices within the PCN that I was thinking in terms of, because if they're not just solely associated or aligned to one practice and they work across a number of different surgeries, it was in relation to that. But I understand what you're saying, that the practice that they're engaged with at that point in time the surgery team in insurance indemnity, they would be covered under that. Is that correct, Nick?
Yes, that's correct. Yeah, under the NHS resolution indemnity program that's in place. So PAs would be part of that and are covered as part of that under normal circumstances. The delegated authority, I think it states that you as a supervising GP would have to have confidence in the competence of the person that you're delegating that piece of work to do. So as long as the GP themselves were happy that they were delegating the work to someone who is confident in doing the piece of work that's being asked of them, your own indemnity would cover you, and NHS resolutions would cover you. As I mentioned, some PAs will have their own additional top-up professional indemnity, but and they would pay for that themselves.
Yeah, I guess it comes back to that competencies framework and that work plan that we have to devise for each of the roles as well. So yeah, thanks for that, Nick.
No problem.
Thank you.
Question, Mike, and thanks for that, Nick. Ryan, is there anything on, and Adrian, is there anything you want to add to that? Anything beyond what mentioned?
Yeah, just to mirror what was said, really, in terms of from a pharmacist perspective, they are very likely to have their own indemnity cover, but equally they would be covered by that central policy, and it would be applied as and where they were working, really. So for all they'd be working across multiple sites, that wouldn't be an issue. I suppose within a segment of that, if we're providing services as a provider, we of course have indemnity policies as well that sit alongside the policies of the practice, just to provide added assurance, really.
Great, thank you, Ryan. And Adria, are there any implications?
Just to add to that, so exactly, because we employ the clinical health and wellbeing coaches, we also have our own indemnity that they're covered under. So as an HN employee, they fall within that, and then added bonus that they do also fall within the PCN. I didn't know that, so that was new info to me, but we have them covered under our policies.
Great. Thanks very much, all. I hope that's helpful, Mike.
Yeah. Just going back to the that other role that young lady was just talking about. Is there a person specification for those type of roles in terms of a minimum requirement to take that on? Adrian,
you mean
that's
health
to you.
Health and wellbeing coaches. So individual PCNs who we've spoken to do have job descriptions, and I know if you look in the DES contract, they have kind of explaining what can fulfill that role or what the responsibilities are. Our specific staff are clinical. That's not necessarily a requirement, but we ensure that they're clinical because we think there's an added advantage to help reduce the GP workload by having someone who has a clinical background to work on disease management, motivation, knowledge, and education. That's not, however, a requirement in the DES outlining the new additional roles. And I think it's around band 5, band 6, I believe, maybe band 4, band 5.
Thank you.
Thanks, Adria. I mean, you'll have Adria's contact details, Mike, and everybody else's, of course. If you do have any further questions or any further queries, do feel free.
Thanks, Damien. We will be getting all of the slides and everybody's details with each of those sets of slides, will we, as well?
You certainly will. Slides and the recordings if you want to revisit the webinar.
Thank you, and thanks for your reply, Adria. Thank you.
No problem. Thanks.
Now, I know some of our panelists have got other commitments as well now, so I will say goodbye. I will say thank you again for joining us. And yes, just to confirm one more time, we'll be sharing the slides, we'll be sharing the recording. Do feel free to get in touch with our experts if you have any queries or questions. Thank you, everybody, for attending, and thank you to our panelists for listening. Thank you.
Thank you very much.
Thanks all. Take care.
Thanks. Bye-bye.
Thank you.